region for pay for performance. So what does the funds look like for this year? We have our base MPAs, which all of you are familiar with. The funding for this year is $15 million. Last year, it was $12.5 million. So we have increased this bucket significantly. Millennium is very, very committed as we earn dollars to maximize and flow the incentive dollars back out to our community and get them in the hands of the providers. So in addition to the base MPA deliverables at $15 million this year, we have also created additional funding opportunities and opportunities for providers to realize incentive funds. The second opportunity we refer to as high impact lists. Our analytics have advanced to a point of maturity that we can now identify for our measures our attributed members who have a gap in care or require a service. So we will now, for certain measures, be providing what we call chase list or high impact list. There will be pretty significant per patient and per gap in care incentives above and beyond the MPA that you will be able to earn depending on the provider type and the measure. We'll go into a little more detail later in the presentation. We have $3.5 million in best practice and innovation funds that will be available to the network. We'll get into the details of those programs a little later. An additional $500,000 that will be used to develop programs that specifically target social determinants of health and the involvement and inclusion in the CBOs in our efforts to improve care and performance and outcomes. So the total for this year is $19,500,000. And again, last year, I'd like to point out that the total incentive opportunity was $12,500,000. So we have increased by $7 million the amount of money that we will be flowing to the provider community. So additional financial concepts. We calculated the awards and for the MPAs, and those are the base agreements that you are all used to, individual provider performance will result in earning money. It is not dependent on us meeting the New York State established performance goals. So in essence, we could fail all our goals, but we've ensured that we have reserved enough money to meet the obligations to flow you the $15 million through this master participation agreement program. The allocation of funds by provider type was determined based on the following factors: number of deliverables, complexity of deliverables, the number of total providers within each category. So there may be a significantly large bucket of incentive dollars dedicated to PCPs, for instance, but because there are so many organizations that money needs to spread across, that had to be taken into consideration. The other consideration is return on investment for deliverables. So we are trying to optimize our pay for performance dollars. The last 2 years of the program, 85% of our funds will be earned by hitting the pay for performance measures that New York State and the targets they have established. Failure to meet those targets will mean that millions of dollars that should have been coming into Western New York and were earmarked for Western New York providers will flow back into the general pot, and they will be absorbed by PPSs in other regions of New York State, and they will receive those funds and distribute them to their providers. So, you know, I want to emphasize when you see what the deliverables are and the continued and escalating focus on performance, that is the reason for that. We also have high performance fund opportunities. We'll talk a little bit more about that, but that is a significant amount of money that the highest performing PPSs make it into. And if you make it into these high performance buckets, the incentive dollars are pretty significant. I'm not going to go over this in detail. This just gives you some information by provider type of how the $15 million was split up. It gives you, you know, what the allocation was last year compared to what it was this year. And in every category, we have increased the dollars, with the exception of maternal and child health, which has stayed the same. I wanted to emphasize that the way that we also determine awards once we've allocated to a provider type is based mainly on your size and attributed lives. This slide outlines for each of our different provider type categories, such as primary care, behavioral health, how we arrived at and what the parameters are for assigning you a size that will impact your award. So obviously, the greater number of attributed lives, the higher size that you are assigned to, and the greater your incentive dollars will be. Now, some practices did change size in MY5 based on updated information we have received. If you are one of those entities, you would have received a letter notifying you of such. If you did not receive that with your amendment, your size and award category remain the same. So, when you are reviewing the MPA documents, the amendments for MY5, we have a new Exhibit A. It's the scope of work and award. And basically what that did was it combined the old Exhibit A and the payment schedule, formerly Exhibit C. So you now have a customized exhibit. We previously had customized exhibits. We've replaced them with standard language for all provider types. And again, we've combined the payment schedule with the Exhibit A, and it includes all your payment information and amount of the maximum allocation. The billing templates that you're used to working with have now become a legal part of the contract and the amendment, and that is where all your deliverables are outlined in detail that are applicable to this year's MPA. So what does the billing template look like? Every deliverable and measure is identified and assigned a dollar amount. The billing template also displays your total maximum award based on your organizational size. And for organizations with multiple provider services, your billing templates will have multiple tabs plus a summary. So for example, if you are a hospital that has hospital-based clinics, you have acute care, you have an inpatient behavioral health unit, and also outpatient behavioral health clinics, you will receive amendments in your billing templates will include 4 separate tabs with deliverables for each of those service areas. So there's an example here in the billing template, kind of outlines for you whether it's considered engagement and reporting. It will indicate whether it's transformation or whether it's performance. It will tell you a little bit about the program. It will tell you that what activity needs to occur, and then how you substantiate that activity to ensure you earn your dollars. The dollars are also included for each of the deliverables within this tool. So what are the incentive components? What are we doing with deliverables this year? As I emphasized earlier, the good news is, I think for everybody, is that we have significantly decreased the number of deliverables this year. So for instance, in DY2, there were 46 PCP deliverables. For the MPAs that closed this past year, there were approximately 26. This year, there are 13 deliverables for PCP. So as you can see, we have taken very seriously some of the concerns that have been expressed by our groups, and we have narrowed the focus and the scope so that it's kind of maximum reward for the most efficient effort. So when we talked about the importance of performance earlier, I wanted to provide kind of a pictorial of how much of your dollars are related to engagement and reporting versus transformational activities, which are like workflow and process and reporting, versus those that really focus on performance. Now, last year was the first year we bucketed a significant amount of money into performance. And with the exception of just 1 or 2 deliverables, I am pleased to report that the vast majority of our network did a tremendous job in the performance category and earned the majority of dollars. I know we were concerned about that when we went out very aggressively with performance, and I know our provider partners were very concerned about that. There were bumps in the road, but at the end of it all, the vast majority of our network was able to earn those performance dollars, and our latest performance results have shown that those have had a very high return for Millennium. So for outpatient engagement and reporting, there's 3% of your total overall award. Transformation, there's 7%, and for performance, there's 90%. Inpatient, the deliverables are, significantly smaller. There's only a couple. Transformation is 25%, and transformation with performance is 75%. It does represent an increase in the dollars dedicated to performance from last year. Last year's dedication of performance dollars ranged from 75 to 80%, depending on provider type. So I wanted to just outline for you what the deliverables will be this year. These are pretty detailed slides. I'm not going to read them. What we've tried to do is indicate what category it is. I'll talk a little bit about why we're still asking for that or why we feel it's important, but the objectives are here. So workforce reporting will continue. That's a New York State requirement that continues through the rest of this year. So we do need those numbers, and there are some dollars associated with workforce activity. The same is true of patient engagement, so that's why those continue to be deliverables for each of your organizations. Again, this is driven by New York State requirements, and there are some dollars tied to that we can earn. In the transformational space, we're going to continue to hold regional behavioral health work groups. We are in the process of seeing what that looks like moving forward, but we will be offering incentives. We feel that provider input and collaboration is critically important. So throughout all of our MPAs, regardless of provider type, we have emphasized and put dollars around participating in our behavioral health work groups. We know last year that the reporting requirements, particularly around performance, were pretty burdensome. So we've actually created an incentive. It's not an insignificant dollar amount that will pay you simply for the reporting that you do. Last year it was via WatchDocs. This year it's going to be a combination of WatchDocs and SurveyMonkey. We'll talk a little bit more about that in the end. So for transformation with performance, these are not new. 7 and 30-day follow-up continues to be a focus. We all know that engagement after inpatient behavioral health into the outpatient reduces readmissions and has better outcomes for the patient. I would like to point out, similar to last year, that some performance measures have multiple targets associated with multiple incentives. So the higher your compliance rate or your success rate, the higher your incentive. But you can only earn one incentive. So the example we have on the screen involves the 7-day follow-up appointment after an inpatient behavioral health stay. If 50% to 54% of your patients comply and show up for their appointments, you receive a dollar amount. And as your compliance rate increases, those dollar amounts increase pretty significantly. So we would encourage your goal to always strive for the highest compliance rate to maximize your dollars. And these compliance rates for each of the measures was not just made up by Millennium. They were based on psyches data, regional, local, and New York State data and best practices, as well as the New York State DSRIP targets that New York State has established for us. So in the performance category for behavioral health outpatient, again, we're emphasizing 7 and 30 days. Substance use is not a really big dollar earner for us in the performance funds. However, we know that it is a big driver of ED utilization and hospital admissions. So we want to continue to focus on substance use. We feel it's the right thing to do for our community. And then also the 3 cardiovascular and diabetic monitoring for the schizophrenics and those on antipsychotics. The mental health follow-up, substance use, as those will continue to be a focus for behavioral health inpatients. So I think we got through that very quickly, and again, it kind of demonstrates that we haven't thrown anything new at you, and we have significantly narrowed the number and scope of your deliverables. We feel that these have the greatest return, and we feel that if you're going to put time and resources into these things, these are the areas that are best to concentrate on. So reporting. We will continue to have self-reporting. There will be patient engagement, which all of the entities have participated in. That will happen quarterly. And the platform where you would continue to report your numbers is Watchdocs. Workforce will continue. That will be twice a year. That will be submitted via HW app. The performance measures previously needed to be submitted via Watchdocs. However, that was very cumbersome, we feel, both for your organizations as well as us internally. So we have created a SurveyMonkey kind of process, which we will talk a little bit about in today's webinar, but for the most part, your relationship managers will be working with you one-on-one. And then other MPA deliverables as applicable, that can vary. Watchdocs will continue to be the tool there. Your first reporting deadline will be October 15th for those things that are quarterlies. That would include patient engagement, workforce, some performance measures that are required monthly. However, keep in mind that those that only require quarterly reporting for performance measures won't be due until December. So patient engagement continues to occur in Watchdocs. For those of you who are not familiar or are new to this process, we have both an email address as well as a number that you can call with any problems or if your staff needs additional training. Workforce reporting will continue to happen in HW app. If you need assistance, again, we provided both the email and the number you can call. We'll be glad to come out and work with your staff or answer any questions that you have. So we are introducing a new reporting mechanism for MY5. We're going to collect your numbers that you reported on last year instead of uploading them into Watchdocs. We are simply going to be sending a SurveyMonkey inquiry around to your designee at the time that the reporting is due. So if you have monthly reporting due, you will receive an email asking for that information. Outpatient contains 4 measures that are reported monthly and quarterly. That includes the substance use initiation engagement, the show rate for 7-day follow-up and 30-day. Those are the measures that the outpatient behavioral health agencies are responsible for reporting. For inpatient behavioral health, there are 2 measures. It's the substance use appointment rate and the mental health appointment rate. And for PPS reported, we will be taking responsibility for the cardiovascular disease and both the diabetic monitoring and screening. We'll be using a combination of psyches and our New York State salient reports, and we will be collecting that information, and then we will be providing the monthly results to each of our behavioral health partners. As our analytics mature, we are very committed to moving away from self-reporting, and Millennium will take on that responsibility as our analytics mature. We will be releasing reporting parameters again this year. They go into pretty significant detail on what is required. It includes the actual deliverable. It includes what your target is, the time frames the reporting should reflect. It gives instructions around the numerator, calculating the denominator, the codes that are involved. Now, this is only a snapshot of the reporting parameters. They also include exclusions and also other special considerations for your numerators and denominators. We are committed to being as provider-friendly as possible within the constraints that legal and compliance has placed. So, you know, last year we came out with reporting parameters. We had a lot of questions. We adjusted the exclusions. We gave you multiple options to calculate the rates, you know, in an effort to maximize your opportunity to meet these targets. These will be released at the same time the electronic version of the billing templates are sent out to you. So for other MPA deliverables, again, these will be watchdocs. Do you know an example of an other? Okay, so there'll be other documentation outside of performance. You know, one of the new deliverables this year is working with your managed care organization to obtain the list of patients they have. I'm sorry, this is behavioral health. That is a PCP deliverable. I apologize. An example in behavioral health for an other MPA deliverable would be the development and submission of a workflow. That's one example. So I want to talk a little bit about the best practice and innovation incentive funds, but I think I want to open it up for questions for the regular MPAs. I'll answer questions around the regular MPAs, and then we'll talk a little bit more about the new incentive funds that are available once we've addressed all of your questions. So we're going to take a look and see if there have been questions submitted via the chat line.
Okay, we actually haven't had any questions submitted via chat, so I'm going to go ahead and open the phone line. So you're all go ahead.
I don't think we have any questions. You know, please be aware as you review this material, as you get your billing templates, as you start reviewing your amendments. As you start reviewing the documentation, your relationship managers are available via email or phone call. I know they also come out and visit you regularly and will be glad to assist you with any concerns or questions that you have.
Got one question.
Oh,
okay, so we got one question, a couple questions. Erica Coots asked, for those who have not reported the substance abuse deliverables on the last measurement year, what would we do for the Survey Monkey?
So our amendments and our billing templates represent all of the deliverables available within a service type. So some of you will not offer every particular service type. For instance, some larger organizations have both outpatient mental health, they have substance use, where others will only have substance use because they target a very specialized population, and or they'll only offer mental health services. So the amendments and the templates represent all of the deliverables available within behavioral health. However, you are only eligible for the awards for services that you actually provide. So within your billing templates, we have taken the steps this year to kind of, on your billing templates, kind of gray out and put where services are not applicable to your organization. Because you will not be working in that space, you wouldn't be eligible for that particular award.
Okay, Kevin Burgess asked, when will the first month of Watchdog's data be due?
So if it's monthly reporting, it would be October 15th. And the reporting parameters will include, last year we included and went into great detail about the reporting timeframes. So for instance, you know, in October, you know, we will figure that out and we will have exact guidance as far as the timeframes, both on the scorecards and within SurveyMonkey, and also the reporting parameters that will be released next week. And Kevin, when you look at those timeframes and the reporting requirements, if you have any questions or you don't feel they're appropriate, feel free to reach out to us at that point. It's so dependent on individual metric, it's hard for me to answer that question very specifically. But we'll get all that information out to you next week.
And then he had another question about timeframes, but I think you just answered that.
Okay. And Kevin, if you want to talk about this even before the reporting parameters or the billing templates come out this next week, just send me an email. I'll be glad to give you a call. Okay. So, in addition to the MPA deliverables, I'm very pleased to tell you about some other incentive funds that will be open to our entire network. So in addition to the MPA awards, you will be, depending on a few factors, you may be eligible for additional incentive funds. So I want to talk about the best practice incentive funds now. And if you recall, best practice and innovation funds had an additional $3.5 million that we're making available to our partners. So best practice incentive funds are Millennium-defined programs. That's a very important delineation between best practice and innovation funds, which we will discuss next. Best practice funds are Millennium-defined programs that are recognized as best practice within the healthcare industry and most impactful on our P4P outcomes and DSRIP deliverables. They may be limited to a subset of targeted providers. That is why they are not part of the MPAs. The MPA deliverables are consistent across the network. Best practice will be a more targeted approach. So if we want additional transformation or to encourage programs for a certain subset of providers, we will define those programs and get the available programs out to you. So some examples, but it's certainly not limited to this, is the submission of unadjudicated claims for incorporation into the Cerner Healtheintent platform to enhance population health management. As you know, we've made a significant investment in the Cerner Healtheintent platform. Between registries and performance, it is our goal to provide the most comprehensive 360 view of a patient that any of our providers can get within this region. So we continue to work on that for some of the largest providers that have the most volumes. You're talking about, particularly the hospitals and the FQHCs. Ingesting their actual claims data gets us that much closer to that 360 view that will benefit the entire region. Another example is participation in the Millennium Population Health Management Pilot Program for chronic disease. Some examples include asthma, COPD, diabetes. Our group is coming in. They're working with individual practices on, for instance, COPD and asthma, medication adherence, inhalers, prescription, spirometry use, monitoring ED and inpatient utilization. In addition to that, Millennium is also offering actual clinical services that we call enhanced patient services that will work directly with patients that require additional care. Another example would be implementation of the Millennium High Utilizer Program. This can somewhat be related sometimes to the chronic disease pilot. Sometimes the two are interrelated. But those are just a few examples of some best practice incentive funds that Millennium will formalize and then offer to providers. We should be coming out with those programs in mid to late October, and they are completely voluntary. We have identified this best practice. We are paying this amount of money for it. It will be your decision as a practice or an entity if you would like to participate or not. One of the biggest advantages to creating the best practice incentive funds and pulling them out of the MPAs is we can tie significantly more dollars to this activity. If it's in the MPAs, it has to be diluted across all the provider types. for best practice, we can offer higher dollar amounts that are more equal to the actual resource and staff time associated with implementing these programs. So as part of the best practice for behavioral health, this is where we will incent your high impact list. So for each of your organizations, it's our intent to provide you with the Millennium specific attributed members. Right now in psyches, you get all Medicaid. We are going to provide you with high impact or chase lists of patients that if the gap in care or the screening is done, is addressed, it will have a direct and immediate impact on our performance measures. So in addition to helping target your MPA deliverables and earning those dollars, the high impact lists offer an opportunity for additional per service and per patient maximization of your incentive dollars. Now, not all partners are going to receive lists. It's definitely going to vary from quarter to quarter. It's going to be dependent on the number of attributed patients associated with the organization, the individual measure, and the actual gap in care. So again, our analytics have matured to the point that we are able now to produce these lists. So Millennium, it'll be a strategy on Millennium's part, depending on how we are performing, as far as which measures we select and what we want to concentrate on from quarter to quarter. So the total MY5 allocation for this incentive, just the high impact list right now, is $500,000. And if it is wildly successful, we will increase those dollars. But again, please think about this. It's a direct impact to our performance measures. So it increases the dollars we bring to our region. It helps your overall MPA performance and earning those dollars. And additionally, how often are you going to be paid $150 to draw a lab on one of your patients? So we hope that this incentive, the way it's structured, is very worthwhile because the return is very big for all of us. So that's kind of an outline of the best practice innovation funds. Again, Millennium-defined. We'll be reaching out to you in mid to October. Now, the innovation incentive funds, in contrast, are provider-led and provider-developed. Millennium is not directing this. Millennium is here to facilitate and support these types of programs. So it's our hope that these innovation funds will create a lot of activity to form provider-led collaborative partnerships that bring multiple provider types together to develop innovative programs and meet established quality and value-based targets. Now, for those of you that participate in the bonus program, this replaces the seed funding. You can continue to submit your programs for funding. They're now known as innovation incentive funds, and this fund is open to all of our network, not just those that participate in the bonus program. So it really promotes a population health and value-driven management approach across the full spectrum of care within this region. We also establish shared performance measures and targets focusing on value and outcome-driven metrics. So that's kind of the reasoning behind the establishment of these innovation incentive funds. So if you're interested, how do you apply? An application for funding must be submitted that includes a description of the program and detailed information on the impact on the particular metric or measure. Who can apply? It is open to our entire contracted MPA partners. Those are all safety net partners. Although non-safety net partners and agencies and non-contracted providers cannot directly apply for the funds, you may invite them to be a secondary party to the program you're developing. The reason we have to do that is most of our funds have to flow through safety net partners, secondary to New York State requirements. So if there is a measure that a CBO or a non-contracted provider can help you reach in an innovative manner, please feel free to make them a party to the program in your application, but understand that you will need some sort of agreement with that non-safety provider because you will be responsible for flowing the portion of funds associated with the program to that non-safety net partner. And we obviously can help you with that, you know, if you have questions around that. So the criteria for funding, this is very, very important because I'm sure just knowing the passion, particularly of this group around behavioral health, there are things that you see every day that you know with a little bit of funding and a little bit of different approach can be very, very impactful. I must emphasize that for this year, all three of the following criteria must be met, or we cannot consider your funding request. So the application must establish a direct link between the program or resources and one or more of our required New York State DSRIP metrics. We'll go into that in a little more detail in the next slide. The impact on the metric is directly and definitively established, is measurable, and can be reported on a monthly or quarterly basis. So there are things that we know intuitively will eventually improve patient care in a more indirect manner. This year, those types of programs are not eligible for these funds. Next year, they will be, okay? So this year, because it's our last measurement year and we literally have tens of millions of dollars tied to our performance metrics, the performance metrics are the focus. Next year, we will have another significant amount of money to fund programs that are more transformational in nature that may take longer to mature and show outcomes. So if you thought of a great idea and I just shot it down because of these criteria, please hold out hope. Those are the types of programs that we'll be looking for during next year's incentive round. So again, you know, the third bullet, the program is expected to have an immediate and direct impact on the metric. Preference will be given to programs or resources that can be implemented in less than 45 days and or prior to January 1st, 2019. If all three criteria are met, the application will be further evaluated by the Innovation Committee that consists of the Executive Director of Millennium, the Chief Network Officer, the Clinical Integration Officer, and the Director of Finance. Decisions will be sent via letter and email within 15 business days of the application submission or following receipt of additional requested information. So here is the focus that the programs must have a direct and measurable impact on. Unnecessary hospital utilization, that would include preventable ED visits, avoidable admissions, 30-day readmissions. Again, our analytics are maturing, so very soon we'll be able to provide some insight on where the greatest opportunity is by provider, by organization, particularly in the PCP space, to a more limited degree for behavioral health, but we are working on that. In behavioral health, that would be 7 and 30-day follow-up, the diabetic and cardiovascular screening and monitoring, as well as medication adherence. Those are the antipsychotics and antidepressants. And then we have high performance measures. I referenced those funds earlier, but doing well, extremely well, in all of the measures listed here. Some are a repeat of above. There's a few new ones, such as tobacco cessation, which is a survey measure, as well as controlling hypertension, which is a medical record measure. We're looking for programs in that space because they are high performance. If we make it into the high performance funds, the opportunity to bring additional dollars to this region and get into our provider hands will vary because it depends on how many other PPSs perform and how we perform in comparison. But this could increase the bucket of money we have significantly by tens of millions of dollars. And just to give you an idea, year to date, we are in the high performance range for 6 of these 11 targets, these measures. So we are performing very well, and it should result in significant additional dollars for investment in programs. I also want to emphasize that although it must have a measurable impact on one of these measures, that doesn't mean that you can't pursue other things. So for instance, if PCP access for patients or engagement in your practice is a big driver of unnecessary ED utilization for a subset group of your patients, we will certainly fund programs that target those patients, increase patient engagement, with the understanding that we will then have to monitor their unnecessary hospital use. The same would be true for substance use disorder. If you identify a group of patients that are visiting the ED all the time and you want to develop a program for substance use that will have an impact on the ED visits, we're open to all of those ideas. Again, though, it has to be a direct and measurable impact in some way. So funds are meant for programs where the program or resource is new and or associated with expansion of an existing program that can only be accomplished by additional investment, and other grants or funding sources do not exist. Funds will not be provided for existing programs or resources that are already in place that will just absorb additional duties. You know, we all know how crazy it is out there and how much we have, and every one of you probably knows the feeling of one more requirement and you don't have money to hire people, so you just absorb it. We really want to fund new resources so that new programs can launch. It can also not be used to kind of cover your existing day-to-day operational expenses or budgeting. These dollars have to be spent on new resources and these new programs. Programs must target the Medicaid population. However, the program is not required to be limited to Medicaid. So when you're developing a program and you're submitting your application, the baseline and your estimated impact should reflect that of the Medicaid population. However, we know that it's, you know, programs aren't implemented by payer. You're going to implement that program for all payers. Just need to ensure that your application reflects the impact and numbers specific to your Medicaid population. And then the funding requested should be proportional to the number of Medicaid lives impacted. So let me give you a couple examples. There are measures where we only need 14 LDLs to be in high performance. So if you can get us 10 out of the 14, and we have to spend some money to do that, that's going to be very attractive to us, even though the number of actual services is small. In contrast, in order for us to hit our preventable ED visits, we need to reduce those by 7,000 visits. So if you come to us with a program that is going to reduce ED visits annually by 50, it's probably something we won't consider worth our investment. So, next steps. The amendment, again, a reminder, automatically goes into effect 30 days from the mailing date. Please review your amendments and the billing templates and the reporting parameters as you receive them. The Millennium relationship managers will then follow up with your specific organization to provide any support you need. Participants in good standing will be eligible and will pay out at 10% of your total value in dollars, your total incentive opportunity in January 2019. And just a reminder that the updated OMIG compliance documentation will be requested again from you in January 2019. It kind of happens every year. So at this time, we are going to open the lineup for questions.
Okay, we did get one more question through the chat. Is there a limit to how many proposals we can submit for the Innovation Fund?
There are no limits. I mean, if you have a great idea that is highly impactful and it's new and it's innovative, feel free to submit your ideas. Again, make sure, though, that the impact on the metric is measurable and that it occurs fairly quickly. As we discussed before, the service dates for MY5 run now through June 30th of 2019. So any program has to be able to launch fairly quickly and have an immediate impact on the numbers and a significant amount on the numbers depending on the target. We also encourage you to engage other partners and collaborate together.
All right, I'll There's no more questions in the chat, so we'll go ahead and open the phone lines. Please do put your phones on mute, though, because we're getting some background noise.
If you can put your phone on mute, it would be appreciated. So maybe they are scuba diving? Great, great. Thank you so much. It sounded like scuba diving from our end. So, are there any questions from the group?
Yes, I have a question. It's Sheila. How you doing?
Hi, Sheila.
Hi. I just wanted you to repeat, when will the applications for these incentive funds be available and the deadline for submission? If you could walk through that again.
Sure, Sheila. They are being passed on to legal for review. That will occur this week. Legal has committed to making them a priority, but I would say that they probably need at least through the remainder of September to evaluate the program, make sure they're legally compliant. It may also be necessary to send out an amendment so that providers can participate in this program. So we are anticipating that the applications will open once legal has signed off on the concepts, but it may be mid-October until we can start evaluating the applications that have been submitted and rendering decisions. Now, as far as deadlines, it is our intent to continue innovation fund opportunities through the rest of DSRIP, but for this measurement year, you know, we're down to 10 months. So those that have a direct and measurable impact on performance need to be developed and submitted as quickly as possible. You know, we're probably going to hesitate to fund something until next year that can't be stood up or have an impact till March of next year, because we only have 3 more months to, you know, impact our performance metrics. So we'll probably give preference to and award dollars to programs that are going to be more rapid cycle in nature. Does that answer your question?
Yes, thank you.
Thank you. Any other questions? I would just like to emphasize one thing. The innovation funds are not to, or the intent is not to fund staffing and resources to manage your MPAs and do well in your MPAs. Each of you will be receiving a pretty significant award from this year's MPAs. You'll have to make a business decision on whether you would like to invest some of those funds to maximize this year's MPAs. Again, this is meant for innovative and new programs. And again, the high performance measures will really be looking for ideas within that realm. Okay, any other questions? Thank you, everybody, for your time and attention. It's greatly appreciated, and we are really looking forward to working with all of you collaboratively as the year goes on. Thank you.